University of Colorado Adult and Child Consortium for Health Outcomes Research and Delivery Science, Pragmatic Research in Health seminar series today. This is a seminar series that is focused on teaching methods around planning pragmatic research and conducting pragmatic research. So the Accords group at the University of Colorado Anschutz Medical Campus does health outcomes, health services, and implementation science research. And we have a number of methodological cores and programs focused on service in providing services around method support, including consultation, training, and grant development for investigators. Our Pragmatic Research in Health seminar series is part of our Colorado Pragmatic Research in Health Conference, which we had our first conference last summer, and we'll be having our second conference this May. And I think I have a slide on that in just a moment. And today's talk is a really fantastic example of a stepped wedge design. And so Dr. Megan Morris and Dr. John Rice, who are both investigators here at Accords, will be presenting on improving communication and health outcomes for patients with communication disabilities. And this is a stepped wedge cluster randomized trial. Before I introduce our speakers today, Jordan, could you go to our next slide, please? Okay, wait, there was another one before that. There we go. So the next seminar in this series around use of frameworks and models for planning pragmatic research will be Dr. Hilary Lum presenting on implementing pragmatic advanced care planning interventions within the health system context. And so if you haven't signed up for that yet, you can find the information about it on our Accords Education website, and we'll also have links to sign up in our upcoming newsletter this month. So put that on your calendar for next month. That's sure to be a really good one as well. Next slide. And I am really excited to introduce our next Colorado Pragmatic Research and Health Conference, or COPRCon, with an overall theme of implementation and conduct of pragmatic research in methods for ensuring rigor and relevance in practice. So looking for the balance between rigor and relevance, will be held on May 24th, 25th, and 26th on the same Learning Times platform that we used last summer. And we heard last year that full days on Zoom was a little bit much. And so we'll be having 3 days that are shorter times with more breaks from 10 a.m. to 3 p.m. Mountain Time. So hopefully people from across the country can participate. And registration links will be coming in the next COPRCon newsletter, along with our call for abstracts. And is that the last slide there? All right. So I believe Megan's going to share her slides, and then John will. All right. So I'll have Megan, why don't you bring up your slides? And I'll give you a little bit of an introduction to our speakers. So Dr. Megan Morris is the director of our Accords Qualitative and Mixed Methods Core. She's an associate professor in the Department of Family Medicine at the University of Colorado School of Medicine. She has a BS in Communication Disorders from Boston University, an MS in Speech Language Pathology, an MPH in Health Policy and Systems, and a PhD in Rehabilitation Science. She's very well educated. And she, as I mentioned, she's our qualitative and mixed methods expert at Accords and serves on multiple health services research studies. Dr. John Rice is a biostatistician and an assistant professor in the Department of Biostatistics and Informatics at the Colorado School of Public Health, and also one of our biostatisticians in Accords. He has his MSPH in biostatistics from Emory and his PhD in biostatistics from the University of Michigan. And he also works on a number of different health services research projects within Accords, including partnering with Megan on this project. And so I'm going to turn it over to them to tell us about their stepped wedge cluster randomized trial.
Great. Thanks, Bethany. So today, our agenda is to talk, I'll first talk a little bit about our long road to funding for this project, and then talk a bit about how we engage stakeholders, especially in the planning of this project. Then I'll give an overview of our study and our outcomes, and then I'll turn it over to John, who's going to be doing some introduction and some education on step wedge study design. So like Bethany stated in our title, this project is about individuals with communication disabilities. As also Bethany stated in my educational background, I am a licensed speech language pathologist and did practice for about a decade. Don't practice currently, but the population that I am interested in studying are those with communication disabilities. And this includes individuals with speech, so speech disabilities, which is difficulty producing speech sounds. It could be someone who has dysarthria or weakness due to a degenerative disease like ALS or Parkinson's. It can also include someone who stutters. Next is language disability, and this is an individual who has difficulty with comprehension and expression of language. So this could include someone with a developmental disability, but also someone with aphasia, which is a language disability that often results from a stroke. And then next we have voice disabilities, and that is difficulty producing different vocal sounds. So an extreme form of this is individuals who have head and neck cancer and have undergone a laryngectomy, so their voice box has been removed, and so they have a voice disability. And then last but not least is hearing, and which is actually probably the largest group in the communication disability population, and something that I'm sure we are all familiar with is, those with hearing loss. A good number of those who are over 85 have a hearing loss, and we all are familiar with age-related hearing loss, but some people can be lose their hearing earlier in life and could also be congenital as well. So this group of individuals with communication disabilities, they actually represent 14% of the US adult population. So they're not actually a small group, but are a significant group of the US population. And like I mentioned in our description, communication disabilities can have a number of etiologies. Okay, so there's data that individuals with communication disabilities experience disparities in care. So one study looked at those who were in the hospital and inpatient units and found that those who had a communication disabilities were 3 times more likely to experience an adverse medical event during their hospital stay. Across the board for those with communication disabilities, they have much lower levels of satisfaction with the quality of care that they receive. In some work that we did looking at sort of the health and healthcare outcomes of individuals with communication disabilities, this particular is those with voice, speech, and language disabilities. And you can see just really very quickly across all of these different chronic conditions that those with communication disabilities, which are going to be for each of our groups graph, it's the columns on the right. Those are individuals with different communication disabilities, and they have much higher rates really across all of our chronic conditions, and that this is statistically significant even when controlling for age, gender, insurance status, SES level, education, etc. And then with access to healthcare, you see that actually those with communication disabilities have roughly the same, they report at the same rate as having a usual source of care when they're sick or for routine care. So you see there's no statistical significance there. But what you find, and this is on the right side of the table, is that they have much higher rates of trouble finding a provider. And then when you go in and do qualitative data to really kind of understand what are the difficulties they have in finding a provider, this is often they're saying, well, I'm having difficulty finding a provider who'd be willing to see me, who knows how to communicate with me. So this grant we're going to talk about today It's all started over a decade ago, and it was one of those which I think many of you, especially if you're clinicians, know this experience of you just have a hunch from your clinical experience. You see, for me, it was seeing patients with communication disabilities and them talking about challenges with their providers, communicating, and then reading in the medical notes from the physicians, whether it be primary care or another specialty. It was very clear in their note. They weren't quite sure what was going on with the patient and how best to communicate. And then I had a personal experience. I have had a family member with a significant communication disability, and I accompanied him to the doctor and in the hospital multiple times, and experienced as a family member, experienced lots of difficulties. And so again, I was seeing that I think there's challenges in how doctors know how to communicate with patients with communication disabilities. So the first study I did, which was actually conducted in 2010 and 2011, was I started qualitatively saying, okay, what's going on here? And that sort of hypothesis generating type of study. And so we conducted a qualitative study with individuals with speech disabilities regarding their communication with their healthcare providers. And in the course of those interviews, really heard lots of stories of challenges of being excluded from healthcare conversations, even being excluded from decisions about their care because their providers just did not know how to best communicate with them. And one of the things that really struck me was a story about a woman. So a woman, she was one of our participants. It was called primary lateral sclerosis, which is a variant of ALS. She was completely nonverbal, but was mobile. And so would go to her primary care and really all of her doctor's appointments by herself, and had a electronic means of communicating. And so to help her healthcare providers and the team, she created this one-page description about herself and her communication abilities and how she would like them to communicate with them. So she would talk about, she would print this out and she would go to the doctor and she would hand it to the front desk person checking her in, and they'd be like, oh, this is great, this is wonderful. But they would then promptly set it on their desk and not share it amongst their team. And so she talked about a lot of challenges with, getting these strategies that she really wanted them to use to the entire healthcare team. And then the next study I did to kind of follow up on this study was in 2013. I conducted a study where for individuals with aphasia, which again is a language disability, typically results from a stroke, we went into their clinical encounters and we video recorded them. And then we sat down with the patients afterwards and watched the videos back. We also surveyed the providers. And what we found from this was that patients had a list of communication strategies that they really wish the healthcare provider team would use with them. But when we asked the healthcare team, say, okay, what strategies should you use with a patient with aphasia and this particular patient, they're able to list what strategies to use, but we're unable to match basically the strategy to their particular patient. And then we asked patients and said, well, has anyone ever asked you what strategies they should use with them? And they said, oh, no one's ever, no physician or no nurse or medical assistant has ever asked me this. And we said, well, have you let them know this? And they said, oh, I just really feel bad. The appointments are so quick and I just don't want to waste their time. I'm not quite sure if I should be telling my providers and volunteering this information to them. From those qualitative studies, I started in 2014, engaged with an advocacy group, and this was a consortium of disability advocacy groups. So there's actually 10 to 15 different groups, and the kind of consortium name was Partnerships for Improving Patient Care, or PIPSI, and they were based out of DC. So I was fortunate to be connected with them through a mentor of mine. And then I actually traveled out to DC and met with them and had, conversations one-on-one with them and say, what are your interests? Your group, what are some research priorities? And this was again around the topic of sort of how do we improve care delivered to individuals with disabilities, particularly those with communication disabilities. And so we had lots of conversations and we discussed their priorities, and we did several rounds of going through different ideas, and so we're able to come up with one idea that we then collaboratively submitted to the Patient-Centered Outcomes Research Institute, or PCORI, and we submitted this to the Addressing Disparities section. And we submitted this in 2014, and we're rejected. We got some comments back, which were helpful. So then in 2017, decided to resubmit. So we resubmitted the proposal. We're promptly rejected. So we're like, okay, but we got some good comments, keep going. We submitted in 2018, and then we got rejected yet again. So we then submitted again in 2019, and we were finally successful. So like they say, fourth time's a charm. I share part of that story just to say, sometimes it takes a while for the grants to finally be funded, and you sometimes need to be very persistent. So this project, we had a little bit of delay because of COVID, but we started officially in July of this last year, and it's a 3-year project. So you can see that we originally started with our project back in, our initial submission was 2014, and it took us to 2020 to finally be able to get started. A few challenges just with engaging stakeholders in this process is there was, as we were going through, the reviewers had some ideas of what outcomes they wanted to see in the study, and they weren't necessarily reflective of the outcomes that the stakeholders wanted. So we had some compromising going back and forth. So that really took some time to figure out. And then also the timeline. Again, we started in 2014. It started the project in 6 years later. And so it was hard to think about how to continue to engage the stakeholders through so much rejection. So I tried my best to, at the beginning, really set expectations, especially the length of time that it takes to get something funded. Initially, we were proposing an idea, and it is what we submitted in 2014. Some of our stakeholders said, well, this is too early. I think we need to do this pilot work before this, and or we need to get XYZ figured out. And I said, yes, but we can do that while we're still submitting these proposals, because it does take a while to get funded. I did regularly meet with these individuals in person. I would fly out every time I was in DC. I'd make sure I'd schedule some time to meet with the stakeholders. And then we also did submit other grants together, including a PCORI Engagement Award, which again helped keep our stakeholders engaged. And then I kept them, I was in regular communication throughout these 6 years. So the objective of the study is to compare the effectiveness and implementation of 2 interventions to increase primary care providers' use of evidence-based communication strategies for the purpose of improving the quality of their communication with patients with communication disabilities. So a few notes about the study is that sort of makes it different and a little bit challenging is that we aren't focused on a specific medical condition. So for example, diabetes or hypertension. So which also made it a little difficult to think about what our outcomes would be because we did not have necessarily hard clinical outcomes, because we were, again, recruiting people, attending primary care appointments, and they could be presenting with a large range of different clinical conditions. So examples, just kind of as an FYI about communication strategies, these are things like maintaining eye contact while communicating, using meaningful gestures, while speaking and writing down keywords while speaking. None of these are rocket science strategies. We just, again, needed to communicate to our healthcare providers what the strategies are that a particular patient needs. And then another thing that's unique about this project is we're sort of across all different types of communication disabilities and this is adults, so 18 and older, so a wide range of etiologies and communication needs. We have excluded those individuals who are deaf and use sign language because sign language is it's a different language, and so an interpreter needs to be called for those types of patients. So if you're familiar with PCORI requires that your studies to be comparative effectiveness. That's a really important characteristic. So you have to compare two effective interventions. This was a little bit challenging for us because there's just not a whole lot of data out there on effective interventions for those with communication disabilities, let alone really any disability. And so, what we did for the proposal, and it was successful, and our program officers actually encouraged this, is really borrow interventions that were effective in other populations and then adapt them for our population and our setting. So our first intervention was an A, which we're calling Intervention A, which is an evidence-based curriculum we had developed for medical students on how to best communicate with patients with communication disabilities. And the goal of this is to review strategies and how to use the strategies. And then our intervention B is what we're calling our patient-directed tool. And this is to empower patients to share their requested communication strategies with providers. So it's we have based it a bit on the Ask Me 3, if you're familiar with that, of having, before you go into an appointment, you say what are the 3 topics you would like to discuss with your healthcare provider that day. Well, what we're doing is we're doing the same thing. We have a list we've developed of 18 different communication strategies. The patient identifies 3 strategies that they want their healthcare provider to use with them during that clinical encounter. And then we're developing a paper version, but also electronic version. And then the patient brings that back with them into the clinical encounter, and it's a conversation starter. So it empowers the patient to advocate for themselves and let the provider know, hey, for this to be a really effective and productive appointment today, these are the strategies I would like you to use with me. So and you can see that this was really also was engaging. It was a bit based off of what that initial qualitative study, what that woman had talked about and which she had developed herself. We have 4 study sites. So here in Denver, UC Health, we have the Mayo Clinic in Minnesota, University of Illinois in Chicago, and University of Michigan. And we are doing 2 primary care clinics at each site. This is our study, our co-investigator team. I've color-coded it by different sites. And you also see our stakeholders there. And one thing I would like to point out is that individuals who have their names underlined, they have communication disabilities. So you can see across our research team and our stakeholders, we have engaged multiple individuals with communication disabilities, or we do have one person who is a caregiver of someone with a communication disability. And then we also have providers. So those names that are in italics, those are primary care providers who are, again, engaged in our study. And then I'll point out we do have policy. So Tina Cordero, who's on our stakeholder advisory board, she works for the Joint Commission and so represents policy on our study. So our aim is to, of the study is to, so first aim is to adapt our healthcare team, which is our education intervention A, and then intervention B, which is our patient directed intervention. We are refining and in particular with the patient directed intervention developing, it's going to be like an app-based tool. And we're in the midst of that process. And then our trial will start this summer. One thing I wanted to point out is that we have an A versus A plus B intervention, so that all of our sites at the very beginning of the study are going to receive the education. And then we will be randomizing the sites as to when they'll be starting the B intervention, which is our patient-directed tool. And John will go a bit more into those, how we'll be doing that. Our outcomes are really guided by RE-AIM. And so AIM-2 is our reach and effectiveness. And AIM-3 is our adoption, implementation, and maintenance outcomes. So this is a table. I know there's a lot going on, but I just wanted to demonstrate and how this is actually from our application, how we explained it to our reviewers is we have AIM-2, you see our reach and effectiveness. And then these are the outcome measures for each of these. And then this is how we are measuring all of those. And so you can see all of there. And it seems like a lot of data, and we are collecting a lot of data, but I also, and we'll go a little bit through this. Another table we put in our application is really kind of demonstrating what data we're collecting at what point. And so you see, again, by reach and effectiveness, we'll be collecting those throughout the entire trial period, which is 18 months. So our main outcome is really patient surveys that we be collecting. We'll also be doing some video recording and then having clinicians complete the surveys. And then we'll be, for more of our implementation, adoption, and maintenance, we'll be doing some more descriptive, qualitative work throughout the project as well. So reach, for the sake of time, I won't go into all these details, but we'll be looking at the proportion of patients who do and do not agree to participate. And again, our reach and our effectiveness are patient-directed outcomes. And this will be a binary outcome at the patient level. Then our effectiveness, so we have two primary outcomes. So again, this was to satisfy both our stakeholders wanted that reported experience to be a primary outcome. So that's what our stakeholders asked for. So we're doing the patient perceptions and quality of care survey, which is a very short 14-item survey on a Likert scale, and they'll be completing that immediately after the appointment. Our reviewers wanted a health-related quality of life outcome. And so we have included the Promise Global Health Measure Survey. This is an item that needs to be, you reflect on the past 7 days. So we'll be collecting that from patients 7 days after their appointment. We do have a range of secondary outcomes. So we're also looking at the patient's self-efficacy. And for a subset of the patients, we'll be looking at the emergency department use and inpatient hospitalizations 6 months post their participation in the intervention. And this we're describing as an exploratory outcome. Again, this was really requested by our reviewers. And then on the provider side, we're looking at their use of strategies through coding of the videos of the encounters. We'll be using what's called the RIAS coding to look at that. And then we'll also be doing surveys with a subset of our providers. And then I am going to move that on to John, who's going to talk about study design.
Thanks, Megan. I'll just go ahead and share my screen. Just give me a second here. So thanks, Megan. I'm going to be talking a bit more about the study design itself, but this is going to cover some of the issues that Megan brought up in terms of the different types of outcomes in the trial, because we have a range of outcomes, including binary outcomes for reach, and then continuous or ordinal outcomes for some of these survey results. So I'm going to start by, the stepped wedge is a particular case of the cluster randomized design as a general family of study designs. So I'll start off with a bit of a background on cluster randomized studies in general, and then some more specifics of the stepped wedge. And finally, I'll talk about some analytic and power considerations. So, what is a cluster randomized trial, or a CRT? Many of you may be familiar with this, but it's an alternative to the classical notion of the individually randomized controlled trial, where randomization happens at the patient level, and typically patients are randomized to one of several arms, at least two generally, and classically these could be intervention and control. And in the Interact study, of course, we're in the comparative effectiveness world. So there's interventions A and then intervention A plus B. So I'm probably going to fall back and forth between talking about control and intervention versus intervention A plus B and intervention A. But in any case, there's a randomization to at least two arms in these studies. But in cluster randomized trials, you randomize groups of patients instead of individual patients. And this presents a lot of challenges, both logistically as well as analytically. So a cluster can be composed of typically individual patients, but it can be any sort of individual unit at which the level at which the outcome is assessed. And oftentimes these clusters are hospitals or clinics, as in the case of the Interact trial, but they could be even larger in terms of entire health systems. And they can also be smaller because a cluster could be something like an individual family. And really the analytical approach is similar regardless of the size of the cluster, but things like power are going to depend on sizes of clusters and numbers of clusters, and we'll talk a bit more about that as well. The key kind of statistical feature that defines a cluster, though, is the notion of correlation within the cluster, because the units within the cluster are going to be more similar to each other than they are to units outside of the cluster, or units in other clusters. And this, again, is kind of what necessitates special considerations for the design and analysis of these sorts of trials. And when I say statistical correlation, you may have encountered things like the Pearson correlation or rho or R, different names for this measure. But in the context of cluster randomized trials, we measure this by the ICC, or intra-cluster correlation coefficient. And this ranges from a value of 0 for complete independence within a cluster, all the way up to 1 for perfect correlation within a cluster. So some reasons to use CRTs are when we have this idea of the level of randomization being required to be at kind of a higher level than the level of the outcome that you want to assess, right? So Megan talked for REACH about the outcome being, it's a binary outcome at the individual level, but we're randomizing at the clinic level. So there's patients at the individual level, and then there's the clinic is the level where we're randomizing. So we have this mismatch between the level of randomization and the level that the outcome is assessed at. So that's a case where the CRT becomes a valuable design. And kind of equally important is the idea that if the intervention can't be reasonably or meaningfully delivered to individual patients, for example, when the intervention is something like a tool or a training program that's given to providers or clinicians, a particular clinician could see any number of individual patients, and within a clinician, it's impossible to, or generally it's often impossible to ask the clinician to, use that tool with some patients and not others, because there's this idea of contamination, right? Because once you've given the tool to the physician, he or she is going to be likely to use it kind of uniformly, more than they would be able to distinguish between randomized patients. So CRTs are often useful in these kinds of cases where it's just not possible to randomize at the individual level. So there's a few types of cluster randomized trial that just a few examples are given here. And these are schematics showing on the rows of each of these panels are the clusters. And again, for the Interact trial, the cluster is of the clinic. And within each cluster, there are patients or individuals or units. So kind of the top left here is the classical parallel arms cluster randomized trial. And in this case, each cluster is randomized to either intervention or control. Intervention is dark blue and control is light blue. And again, this is a little bit different from the comparative effectiveness world, but kind of the language is different, but the concepts are the same. So in this design, each cluster stays within their assigned randomized group for the duration of the study. And this design is kind of best for statistical power when there is a low degree of correlation within a cluster, so a small ICC or an ICC close to 0. So one alternative, if for various reasons, power is one of them, is this parallel cluster with baseline period. So the upper right panel here. So, which is similar to the parallel cluster design, but now we have an additional baseline period. So the first 3 clusters in this example spend half the study in control phase, and then they transition to the intervention phase. So this can provide a little bit of a boost in power when you do have a greater correlation within units, or sorry, within clusters, between units within clusters, because now you're able to make, some clusters are serving as their own controls here. And that provides benefits because the correlation in that case is beneficial in terms of your test statistics are differences between two random variables that are correlated with one another. And not to get into too much technical detail, but this can be advantageous when there's a greater degree of correlation within the cluster. And this is kind of a combination of some of the traits of the parallel design with the stepped wedge, which is depicted in the bottom 2 panels here. And you can kind of see just graphically that these are nuances of the top right here, where now we have all clusters are starting in the control phase, but then in this kind of sequential pattern, they cross over into the intervention phase. And so it happens that each cluster contributes data or patients during both the control and intervention phases of the trial. So they're all able to serve as their own controls. And the random part here is the order in which this happens. So the way this works is that cluster 1, these labels are kind of arbitrary, but that cluster would have been randomized to go first. So that cluster would contribute a single time period of the study to control, and the remainder of the time periods of the study to intervention, all the way up through the final cluster here, cluster 6, which contributes most of the data to control, and then a single time period to intervention. But the key point here is that as all clusters eventually get the intervention. And then the last kind of variant shown here is the addition of a transition period, which can be helpful if there is a kind of a need to spend time implementing the intervention in each cluster. So as I said, in the step wedge design, each cluster is acting as its own control because it provides data both pre and post intervention. So in control phase and then intervention phase, or in the Interact trial in intervention phase A and then intervention phase A plus B. So the times at which the crossover occurs are randomized. So the study design can be kind of characterized by the number of clusters, the number of time periods or crossover points, and then the number of individual patients per cluster per period. And I have another schematic here to show this a little bit more detail. And the most powerful design is has each cluster crossover at its own time points, But it's also possible to have several clusters crossing over at each time point. And this can be done for feasibility or other reasons. So when the ICC is large, or as the ICC grows, the stepped wedge design presents an increasingly great advantage as far as power goes relative to the parallel CRT. And the transition period, as I mentioned, which can be introduced for logistical reasons to avoid kind of contamination, will possibly reduce power, in some cases substantially, because, in a sense, the most information you're getting on the treatment effect, which is the comparison between the two arms, is coming in that kind of diagonal portion of those graphs. So when you're losing data there, it can have a greater impact on power than if you lose data on kind of either end of your study. So some more pluses and minuses of the stepped wedge design. I've talked about a few now, but the primary advantage, I think, is the increase in power that can result when you're in the setting where you have to do a cluster randomized trial. Because this is greater for a stepped wedge generally than for a parallel arm CRT, assuming you have an ICC that's a bit, in at least a moderately, large range. And one of the drawbacks, of course, is that transition phase, and that's often needed to get the intervention up and running, because you need that to avoid some contamination. But again, that can kind of decrease some of your power gains. So it's important to weigh these considerations out. There's also some other logistical challenges that come up because of the time dimension. So more data points need to be collected for each patient, because you don't only need to know if they're in intervention or control as you would for a parallel arm CRT, you also need to know which time period they were seen in. Because when you go to analyze the data, there's the part of the analysis involves using the information on time period to control for secular trends. So this can also be, this is just a greater burden of data collection and recording that's involved. Another problem that can result is when, if your outcome is assessed at more than a single time point, if you have to assess change over time or a time to event outcome, this ideally the outcomes are measured at a single time point. So they can be unambiguously assigned to a certain phase of the study and time period. And what happens when you have these outcomes that are either changes over time within a patient or times to event or various other things, is that you can have patients kind of spanning more than one phase or period of the study. And this can present a challenge because, where do you assign that patient? And there's intention to treat analyses, and there's various sensitivity analyses that can be done, but that's one of the disadvantages to the stepped wedge, is if you have an outcome that needs to be assessed over time. So there's also some analytical challenges that result from that, but I'll talk a bit more about that later. So the INTERACT trial specifically, as Megan outlined, we have two interventions, which is kind of, the stepped wedge is best approached with two interventions. You can look at more than two interventions in other cluster randomized designs, but with the stepped wedge, it's typically two. And in our case, it's intervention A, which is the healthcare team directed, and then A plus B, where the patient directed piece is kind of added on to what's already been implemented. And we have four participating health systems, each contributing two clinics, and the clinic is the unit of randomization. So we have essentially 8 units that we're going to randomize. And then in the stepped wedge design, we have all of our clinics are going to receive that healthcare team directed intervention from the beginning, and then in random order, the clinics begin to receive the patient-directed intervention. And in practice, this random order is kind of done by just permuting the clinic IDs into a random order, and then that becomes the order in which they receive the intervention, or the B intervention. So again, in the step wedge design, each clinic starts in phase A and then ends in phase A plus B. And then kind of the randomness results in how much data from each clinic is coming in phase A versus phase A plus B. So this is more specifically for the INTERACT study, what the design looks like. So we have these 8 clusters or clinics on the rows of this table, and then we have the 9 time periods on the columns here. And then the number in each cell is the number of patients that we're planning for reasons of power, planning to recruit or enroll in the study. And you can see that this is a relatively simple design in that we have the same number of patients expected in each across the design of the study, both between clinics and between time points. And this does simplify things like power calculations, but it's by no means necessary for the stepped wedge. There are certain designs that, again, with the transition period, you could have fewer people being collected along that diagonal. And again, there's implications for power there. But the light blue, again, is phase A, and then the dark blue is phase A plus B. And then one thing that we are kind of still considering how to address is imbalance due to randomization. So a lot of the times with cluster randomized trials, there's concern about balance between arms. And that's just as true for a stepped wedge. But the methods that we use to deal with this in a traditional 2-arm CRT, such as covariate constrained randomization, are complicated in the stepped wedge design because of this time dimension. So not only do you need to deal with the fact that where the clinic is randomized is going to impact how much data it contributes to the control arm, or A arm versus the A plus B arm, you also need to kind of consider balance over time as well. So again, this goes back to the logistical challenges that can be presented by the stepped wedge. So the statistical model that we use is presented here, and this is characterized as kind of a mixed effects model. So we have fixed effects, which here are represented by mu and beta and theta, and then we have random effects represented by alpha and then E here. So these random effects are random variables, and then these fixed effects are parameters that we want to estimate. And theta here is the treatment effect. So this is the difference in means between the control and intervention phases of the study. And then the random intercept here, as this is known, is specific to each clinic, where clinics are denoted with the subscript I. And this is what allows us to analytically account for the correlation within a cluster. And then there's additionally a time effect beta, where J indexes time, which is necessary to control for secular trends in the outcome. And then you can notice as well that the treatment indicator variable X has subscript I and J, because each clinic or each site or cluster is going to go through both control and intervention phases. So this needs to depend on time as well. And then Y here is kind of the outcome itself, which is represented by the conditional mean plus random error. So the analysis of this kind of data is typically done, in the mixed modeling framework, and the outcome can be in various forms, including continuous or binary or count data. With binary and count data, you're in the generalized linear mixed modeling framework, which presents different analytic challenges in terms of numerical aspects, but the overall approach is similar. The model looks the same. There are a few different functions that appear in terms of links and things like that. And of course, the coefficients are interpreted differently. For example, if you have a binary outcome, the coefficients would be interpreted as log odds ratios rather than differences in means, things like that. And typically, again, we analyze the data at the individual level rather than the cluster level, and we use either GLMMs or generalized estimating equations, or GEE. But there are some special cases where you can analyze at the cluster level. And typically this would be limited to things like a normally distributed outcome and equally sized clusters, which is obviously a limitation because with the individual level analysis, you don't need to worry about that because it's all accounted for in the modeling process. So finally, I just want to remark on the importance of this time effect, because it's kind of a key aspect of the study design here, is that the treatment depends on time. So when each cluster receives intervention A versus A plus B in our context depends on time. So you need to account for the time effect in your model with that beta coefficient in order to avoid bias in your treatment effect estimate. Because if you fail to account for that, then again, that'll result in potentially biased estimates. So I'll turn it back over to Megan now.
Yep, we just again want to acknowledge the study team, because this is a big effort, and so thank everyone, and then finally PCORI, who funded this study. So
thank you both so much. That was really interesting. So we do have a few minutes for questions. And it looked like we had one question about wanting to access the curriculum you wrote for medical students. And so you're going to send that out to the person who asked. And so then we do have a few general questions that were sent in advance. And anyone else who has questions, feel free to submit those through the Q&A. Okay, so some of the advanced questions that were sent in. Do you have plans to develop new mobile applications to improve health outcomes for patients with communication disabilities?
So part of this kind of phase of this study, we are creating this mobile application that it's web-based and can be used on a tablet or a phone, and it's really stepping the patient through of there are evidence-based communication strategies, and so we've kind of refined the wording of them and how to describe them, and then they pick which ones they would like kind of the person they're speaking to use it. So we are designing it and focused on the primary care setting, but in theory, this could be, hopefully once we determine this is effective, and we've had lots of requests of integrating this into the EMR. So it could be used kind of across the care continuum and with different providers with patients. But in one of our focus groups, actually a patient said that he uses something, or he's developing something similar to use with first responders. So I think it could be extended actually outside the sort of the healthcare setting, but that's the only thing we're working on at the moment.
All right. And I just want to mention that if you do have to log off, please make sure to do the evaluation. You should be getting a notification about the evaluation. And so we have time for a couple extra questions, but please do the evaluation. Okay, let's see. So there's a couple sort of comments here. So one person said they're interested in outcomes for patients with expressive aphasia and tips for caregivers. Do you have any sort of reflections on opportunities in that area?
So expressive aphasia. So this is someone who aphasia is a language disability, so kind of difficulty sort of expressing themselves, their language. So they might, see something or like, I know that's a tree, I just can't tell you that it's a tree. And so, so we, again, our our study is really not addressing, again, I'm a speech language pathologist, but we're not really addressing like treatment outcomes necessarily, but how do we modify the environment that can really maximize the abilities of these individuals to participate. So if you're familiar with the World Health Organization, ICF model, we're really focused on sort of participation and intervening on the environmental factors, but we, through our focus groups, really trying to develop our interventions and our outcomes. We have engaged people with all types of communication disabilities and have used different strategies, such as like visual cues to kind of elicit their preferences and how they even want their, like the survey items to be represented to them. So.
We have time for one more question. We like to end a little early if possible. So have you heard about the medical student education program for patients with communication disorders at the University of Washington? Maybe still in a pilot phase, and any reflections on that?
Yes, I developed it. I had the first grant to develop that back in 2010, which is where I did my PhD. So yes, I'm very familiar and work with those colleagues still.
All right, well, thank you both so much. And we will, so the link to the evaluation is in the chat. If you could do that for us, we really appreciate it. And we did record this session and it will be archived on our Records Education website. And please keep an eye out for registration information for COPRHCon 2021. And we hope to see you at some of our upcoming webinars. Thank you, everybody, and hope you have a good week.
Thanks, everyone.
Bye.
Bye.